In this video, we describe how to dissect the ischioanal fossa. This work was created by Dr. Carlos Andrés Suarez-Quian and Dr. Joel Volensky. Dr. Suarez-Quian is the narrator of this video. You will never forget the pain if you ever experience an anal fistula. In this dissection, you will learn where they occur and identify the nerve responsible for the pain. The area we will discuss in this dissection is the ischioanal fossa. It is a fat-filled space lateral to the anus. There's nothing much of importance that runs through the fossa except the inferior rectal nerve and vessels that supply the rectum. If a fistula of the rectum occurs, painful infections of this area result. Generally, it is the first area of the pelvis to dissect to subsequently allow dissection of the rest of the perineum. Let's start the dissection of the ischioanal fossa. The dissection begins by placing the cadaver in the prone position and becoming oriented. As the dissection proceeds in the pelvis, you will learn quickly that it's easy to become disoriented as to what is medial and what is lateral. I always recommend to the students to think of the anus as the midline. Because this is a female cadaver, we can discern the vestibule of the vagina. Now, we palpate the area of the ischioanal fossa, although this can be difficult in the embalmed cadaver. The dissection begins by making a midline incision with a scalpel on one side, then reflecting the skin and superficial fascia together, and repeating the same procedure on the contralateral side. After removing the skin and superficial fascia, we expose the gluteus maximus. Again, note the anus as your point of orientation for the midline. The fat-filled ischioanal fossa is now apparent. We now have to reflect both gluteus maximus. Do this by using a scalpel and cutting through the bony attachment of the muscle, first from the sacrum, then from the ilium, and then reflect the muscle laterally. However, this reflection is easier said than done because just above the ischioanal fossa, the muscle also takes its origin from a ligament, the sacrotuberous ligament. Hence, the muscle needs to be scraped off from this ligament to fully reflect the muscle. If you reflect appropriately, it is possible to retain the ligament as shown on the image. First, identify the reflected gluteus maximus and the midline point, the anus. Deep to the gluteus maximus is the gluteus medius, and the piriformis muscle can also be detected. We will not study these muscles now. They are muscles of the lower limb and will be studied when we dissect it. Our interest is the sacrotuberous ligament, one of the ligaments that helps stabilize the pelvis so that it does not pivot when we stand up straight. As to why the ligament is called sacrotuberous ligament, that one is easy. It extends between the sacrum and the ischial tuberosity, the part of the pelvis on which we sit. The goal now is to use scissor technique to remove the fat from the ischioanal fossa until reaching its walls. The only content of the fossa, besides the fat, is the inferior rectal nerve. Unfortunately, it is often lost during the dissection the first time you perform it. Also, the distal attachment of the sacrotuberous ligament needs to be cut and the ligament reflected superiorly. This is what the area should look like after removing the fat and reflecting the ligament. Note the reflected sacrotuberous ligament. The medial boundary of the ischioanal fossa is the levator ani, which also helps to form the pelvic floor. Why is this the medial boundary? Note the anus. There's also a lateral wall, this one formed by the obturator internus muscle. I would also like to point out the sciatic nerve. but simply because it is there. We will study this nerve more when we dissect the lower limb. Let's zoom in now into the ischioanal fossa to better identify structures found in the region. Let's label the structures we know already: the anus, the sacrotuberous ligament, the sciatic nerve, the ischial tuberosity, and the levator ani, forming the medial wall of the fossa. Note the probe deep to the medial wall. In reality, the obturator internus is covered with a deep fascia that separates inferiorly to form the pudendal canal. It is here we find the pudendal nerve and the internal pudendal artery and vessels, which are now labeled. The nerve and vessels become the dorsal nerve of clitoris or penis. We will find these in the next dissection. Finally, the inferior rectal nerve is present and labeled. This is the first branch of the pudendal nerve and does not enter the canal, but rather enters the ischioanal fossa and travels to the anus. The sensations of painful hemorrhoids and of an infected ischioanal fossa are sent via this nerve, which is somatic. The identical structures are found in the male cadaver. First, we zoom in and then label the pertinent structures: the anus, the sacrotuberous ligament, the levator ani muscle, the obturator internus muscle, the pudendal nerve in the pudendal canal, and although the inferior rectal nerve was not maintained in this dissection, the accompanying artery and vein traveling to the anus were. Finally, we can discern the external anal sphincter. This is a voluntarily controlled muscle. This now concludes this brief dissection of the ischioanal fossa.